So I really think historians and economists need each other.
Hey there, fellow rethinker. Welcome back to the Rethinking podcast. In this episode, we talk with Christy Chapin. Christy is a historian that dove deep into the US health insurance system and found plot twists you won't see coming. Where did the present health insurance system come from? Probably not where you think. According to Christy's research, the free market did not set it up. Christy takes you through the history of the health insurance system in the US, from prepaid physician groups to the AMA. She explains how incentives affect the healthcare provided and how they rack up costs. Welcome to the world of hidden factors that change the course of US health insurance. Enjoy! Hey Christy, welcome to the Rethinking podcast. It's so nice to have you. This episode is all about your expertise in the history of health insurance in the US, which I'm super interested in. So where does that history start?
What would be kind of silly for me to say it starts at the beginning, wouldn't it? I do need to come up with a clever line for that. I would probably start my accounting of the modern US healthcare system actually at the end of the 19th century, just because actually looking at the history of science, believe it or not, before we look at politics and economics, because with the discovery or the popularization of germ theory, that's where we get the launch of what a lot of people refer to as modern medicine. We get some of the first efficacious medicines and vaccines. And of course, this is very important for mortality and morbidity rates, but it's also very important for the power that it accords to organized physicians. And in the United States, this is very important because they use this new prestige, this new social standing that they're getting from this rise of science and culture's fascination with science. They're using that to get political and social power. And in the United States, they make a push to get licensing laws. And they have to do this on a state-by-state basis just because, the way our country is governed. There were already some licensing laws on the books, but where they existed, they were weak. So they were looking to get them strengthened in order for physicians. And in the United States, organized physicians are mostly recognized under the American Medical Association. That's at least when we're looking at the history, particularly pre-World War II. And so the American Medical Association wanted to get these licensing laws. And a lot of people think, what's the big deal about licensing physicians and making sure they went to the correct college? But what people don't realize is something as simple as a licensing law in the United States, the way it functioned is it basically, because the AMA controlled the licensing boards, it basically gave regulatory control over the medical market to the AMA. It's one of those unintended consequences. Now, that's not the case anymore. AMA does not have that much control over the state licensing boards, but definitely at least through the 50s and into the 60s, they did. And this meant that any physician that did not only, it wasn't just about going to university, sitting for your board exams, proving how much you knew medicine. It was also proving that you had the exact political and economic behaviors and beliefs, or at least said you did, in order to get your license. This meant that a lot of types of economic experiments that physicians were doing with healthcare, some of which were very elegant and wonderful ideas, they weren't allowed to do because they were fearful of losing their license. And that's what the AMA did. When somebody stepped out of line, they would have their license pulled or they would go after it. And unless you're a very powerful physician with, political contacts, that's just not something you're going to do. You don't want to waste your career by going up against the American Medical Association. So that's why I would start the story of how we got to where we are today, all the way back at the end of the 19th century, is looking at how the AMA and organized physicians were amassing this political power, this economic power, this social standing, and this prestige that's really going to aid them for a long time. Now, they just don't have that same type of power they used to have. So please understand that I'm not saying that today. Yes, the journal article will always mention what the AMA thinks. They'll always be pulled in for the negotiations, but they're not nearly as powerful as they used to be. So I can keep going from there, but I don't know if you have any questions, or should I keep on telling the story? Because it is a fascinating story.
I really do want to hear the whole story, of course, but how where did you see the changes then from the AMA buying these licenses? Because how does that work? The AMA is the overall United States, and then they bought licenses per state and then made them all the same. How does that work?
Oh, okay. Yeah, let me explain. I'm glad you asked that question that way because I need to do some more explaining for how medical licensing works, especially since I'm talking about the United States and it's going to function differently in so many in different countries. In the United States, in order to practice as a physician, not only do you have to go to medical school and pass your boards and do your residencies and such, in order to practice, you need a license to practice medicine. And it used to be, back in the 19th century, that anybody could practice medicine. And really, medicine, I kind of have to chuckle. It was in such a state that, you have a good couple of handbooks. That's pretty, a year apprenticeship. I mean, really, there's
Oh,
not a
wow.
whole lot they can teach you, right? I mean, they're things like bleeding people and purging them. Okay, that's starting to fade around the mid 19th century, but still, really, there's not a lot they can do. There's, opium and the kitchen table surgeries and such. They still don't know what causes disease. They still don't know what causes infection. And also, my students are always surprised to find out how much the medical students and physicians were ridiculed in popular culture because they were so looked down upon. I mean, there's stories of mothers crying because their sons want to become doctors, which was the opposite of what we think today, right? Because there would be, I am trying to remember some of the jokes about, too amoral to study to be a minister, not too stupid to study for the bar to be a lawyer, so go into medicine. Those are the kind of jokes.
Oh my goodness.
And the medical schools were a joke. I mean, talk about anybody who really wanted to be a physician of prominence in the 19th century really had to go to Europe. They would go to England or Scotland. Early 19th century, France became hot. By the end of the 19th century, it was Germany. That's where you went to get a true and proper medical education. In the United States, we had medical schools everywhere because if you just had an empty room and a doctor, somebody who just calls themselves a doctor, that's all you need to open a medical school. They were more concerned usually with getting fees. So it's not like they really care what there weren't, stiff requirements to get in. And there were reforms at the end of the 19th century. Harvard starts to reform. Johns Hopkins gets set up at the end of the 19th century. That becomes the model. And Johns Hopkins tries to model itself on European institutions where there's research and practice, and you have the university and the hospital and also a nursing school as well. So, so this is kind of giving you a little bit of an idea of why modern medicine is going to be so important, because before, the physicians just aren't seen as, they don't have a lot of social standing, they don't have a lot of prestige, they're not looked upon very highly. But now I would argue our culture is just almost worship science. In kind of a bad way. We have a lot of scientism going around. People say a lot of, if science said, but people try to whatever your belief is, if you can wrap science around it or scientism around it, right, it's going to give you a lot more legitimacy just because of the type of culture we have, right? 200 years ago, it might have been the Bible. Now it's science. So once physicians have more power here in the United States, they do a very good job, I've got to say, of really holding on to the healthcare market. Now, I would argue, of course, it didn't work out well for everybody. I would argue that they even actually shot themselves in the foot and did things that ended up really hurting physicians long term. So as I tell the story, so basically they get these licensing laws passed, which means, let me just explain that a little more to make sure everybody understands, which means that for a physician to practice medicine, they have to get a license after they go to school. So that gives AMA a lot of power to start even saying what medical schools count for you to sit for the licensing exam. So that's going to allow a lot of medical school reform, some of which is definitely needed, right? Because as I'm saying, some of the medical schools were very, very poor. So around the beginning of the 20th century, we start to see the medical schools reforming. Okay, so that some of that's good. But then again, also, you've got to realize with us decreasing the number of medical schools we have, you're also going to see it's going to be harder for people who are poor. It's certainly going to be harder for, ethnic groups, for African Americans, Asians, women. They're going to kind of get pushed out because once you really formalize it and make these legitimate institutions, it's going going to be much more difficult for people who are outside of the mainstream to get a medical education. So although, the quality does improve, the cost also increases a good deal. So because the AMA is controlling these licensing boards, they're deciding what you need to do in order to be qualified to even sit to take the exam. So then you take the exam. And then, as I said, along with testing your medical knowledge and whether or not you have enough skill to practice as a physician, they're also checking to make sure that you fit the social profile they want, that you're not too leftist, right? That you're not too radical, that you don't have any crazy notions about the way medicine should be practiced, or at least what they would call crazy notions, right? Unfortunately, the AMA, well, I'll get to that point in a little bit, but this is how they're able to use something as simple as you needing a license to practice to really get regulatory control over the entire market. So you see what I'm saying? It's kind of a backdoor way of putting the AMA in charge of that market. That's not what politicians meant to do. It's just what happened, especially when you're looking at the United States during this period at the end of the 19th century, beginning of the 20th century. There certainly isn't a lot of federal government. That's more going on at the state levels anyway. But so you can see how this area of policy just gets kind of handed to them. The problem is that in the first, I would say, 3 or 4 decades of the 20th century, you see a lot of interesting experiments in the medical market in the United States. I could go through practically dozens of them. You have unions starting their own welfare funds, right? One of the really neat experiments we see is a lot of these mutual aid societies or fraternal orders. In Europe, you have them more as like the friendly societies and such. In the United States, every immigrant group and African Americans locally, most of them joined what we call mutual aid societies, or they were little fraternal orders at the time. They were kind of like social clubs, but as you paid your dues, they also functioned to provide Social Security for members. So they very often provided life insurance, was a very common thing. And then they also started doing things of providing a rudimentary form of health insurance where they're contracting with a physician, sometimes even a hospital. We even saw a case where one very large African American mutual aid society built their own hospital using member dues and such. So during this period, we're seeing all these different experiments with how do we make medicine more accessible, right? How do we figure this out? It's always been important, but now people are really captured by medicine. It's modern medicine, and surgery is advancing, and they're figuring out antibiotics and penicillin, and people are getting just very, very excited about medicine. So of course, now they want to avail themselves of these new treatments, even, new, clean, more modern hospitals and such. But the problem is, of course, the prices are rising. And with healthcare, the difficulty of healthcare is it's very hard to budget for, right? When you're looking at hospital costs and stuff, right? You might not have much healthcare bills this year, but next year somebody goes in the hospital and they skyrocket. That's very difficult for a family to budget. And so of course people want to find insurance mechanisms, or what they would often call prepaid plans, which was just a synonym for insurance at the time. So that's why I'm mentioning there were all these different experiments. Like I mentioned the fraternal orders and the mutual aid societies and the union welfare funds. I'm going to mention one by the physicians, because I think this would have probably been the dominant model if the AMA had allowed it to live, which it did not. And it's interesting too, because it shows physicians fighting against the AMA, basically. They were called prepaid physician groups or prepaid doctor groups. And this is just, physicians came up with this on their own. It was just a natural way to practice medicine, if you think about it. They were physician groups, which of course we have today, but today in the United States, our physician groups are single specialty. These physician groups were multi-specialty, which solves the problem that we have today of fragmented care. This way they had integrated care, right? Think of one-stop shopping, all your different physicians that you might need in one spot, right? So you could have these, being early in the 20th century, they would have had, say, surgeons, obstetricians, pediatricians, general practitioners. You might have some ophthalmologists, but you have all the different types of medical practitioners there. And this is really important for people, not for young and healthy people, but for people who are chronically ill, who are older, maybe have a number of conditions, have a difficult to diagnose condition, because that's where you need sometimes more than one practitioner from a different discipline and a different specialty kind of looking at the patient and trying to figure out what is going on. And that's what they would actually do in these practices. At the end of the day, they would sit around the table and where are the difficult cases that we can't figure out? Let's talk about it. Much more exciting way to practice medicine. You talk to physicians today, if you're single specialty, you're in your whatever procedure it is you're doing, you're just doing it over and over and over again. It gets to be very dry. But if you're practicing in a way that you're learning from your colleagues across specialties, across disciplines, and you're problem solving, that's just much more, things are a little bit more different. It's a little bit more novel, creative. That's more of the art, right? Where you see the art of medicine and not just the science. So it was a great way to practice medicine. It delivered high quality care because of the fact that the physician group owned, so to speak, the health of that patient. They were responsible for it. The unfortunate thing with fragmented care today is if somebody's very sick or has an illness that's difficult to diagnose, they just get sent from one physician to another. Okay, we did all the tests we could. Now you need to go to the next specialist. Okay, we did all the tests that we can charge the insurer for. Now you need to go to the next specialist. And, you might die in between one specialist and another. That information isn't even ever going to get fed back into the system. None of the physicians who saw you are even going to know. It's, supposedly general practitioners manage our total health profiles and everything that we have going on with a number of specialists, but how could they possibly, that's impossible for them to do with the amount of time they have in a day. They can't be on the phone consulting with a number of different specialists for all their patients. It's just, they can't. They do sometimes, but it's very limited. It's not what people want it to be at all. So this is a big problem we have. Nobody, if you're really sick and there's something wrong with you, there's nobody who really has to find out, right? And there's no even economic incentive for there to be, unless you can just get the money together to go to one of these really, great, like say the Mayo clinics or the Cleveland Clinic or something like that. So the prepaid physician groups solve the problem that we have today of fragmented care by providing holistic integrated care. The other thing that the prepaid physician groups did that was so elegant was kept costs in control. And that is because the way they were set up is basically the physician acted as their own insurer. Instead of having an insurance company involved, right? The physicians themselves, the physician group itself insured itself. So the patients, the way it worked is patients, there was an individual rate and then like a family rate, just like there is today with insurance in the United States. But instead of you sending your payment to an insurance company, some corporation far, far away, probably in New Jersey, instead of you doing that, or Connecticut, or New York, you would send it to the local physician group. And this was really important because of the way it incentivized physicians. It incentivized them, if they really just didn't care at all about people and only cared about making money, it is in their best interest to keep you healthy, because that means they don't have to spend their resources. So today you hear people who complain about rationed care and care being withheld. And that is a problem when the provider of care is not incentivized, on the back end to make sure that you're healthy, right? If there's no other balancing act on that, then that can be problematic. But in this case, it was balanced perfectly because it didn't make sense for them to try to kind of unneedlessly withhold care. Because first of all, you're going to lose money because people are going to say it's not worth it to go to that prepaid physician group. I'm thinking of let's think of a modern day example. I've had headaches for 2 years and they won't give me an MRI, right? So that's the worst publicity. It's the last thing you want. And also it would also be shooting them their own selves in their foot if they were just needlessly withholding care, because then if you do get sick, you're going to end up costing that physician group more money down the road. So it's better just to find out, and also to keep you healthy and to make sure you're eating properly, right? If you're diabetic, they're going to be very concerned about making sure you understand nutrition and that you're eating well and you're exercising. You see, now the physicians are starting to be incentivized a little bit more than just tossing advice at you, but that to really actually care. And hey, maybe we should bring in a nutritionist. Maybe we should have a class once every week, and maybe all these other things that we could imagine would happen if they were incentivized properly. So at any rate, they were incentivized to keep their patients healthy, not ration care, but also not needlessly over provide care. That's a problem we have today in the United States, is that people with insurance, physicians and hospitals sometimes try to run up the bill I'm not saying there's anything particularly wrong or bad with physicians. They act like human beings. They act like professors would and journalists would and such. They act according to how they're incentivized. Some of the reasoning they might tell themselves is, I have to run up this bill to make up for my Medicaid patient, maybe. Or they might say, I need to run up this bill because I can't get reimbursed for this other thing. Or this is gold standard treatment. I'm throwing all these tests and procedures at the person. That's what I'd want from my family member. That's the kind of reasoning we would all go through in order to act along the lines with our incentives, right? These prepaid physician groups had no incentive to needlessly provide procedures, because obviously, again, they would just be taking money out of their own back pocket. This is really important. If you look at healthcare systems around the world, I would say one of the key problems we have is, how are the providers incentivized? I think we sometimes focus a little too much on the patients and stuff. To me, it's the providers, the one with the expertise, right? They're the ones with the requisite expert. When you're saying, I want you to walk a tightrope between overutilization and rationing care, well, who's going to have the expertise to make that decision? It's going to be, the physician, the nurse practitioner, the hospital practitioner, whoever it is providing care. And yes, they're going to be doing that, getting input from the patient and such, but that's really where we need to have the incentives lined up correctly. And so that's why these prepaid physician groups were so brilliant. Progressives loved them. This is what, for a very long time, until the late 40s, early 50s, this was the model that if we had universal health care in the United States, this is what the progressives and the reformers, even in the Social Security Administration under Truman, this is the type of model they were pushing for. Progressives loved it. Consumers loved these prepaid physician groups. There were hundreds and hundreds of them around the country, but basically it got very difficult for them to continue. Only the most politically connected ones were able to continue. The AMA went after these physicians. They had their licenses pulled. They warned them in the Journal of the American Medical Association, at the time, still is, and at the time, one of the world's top scientific medical journals. And yet they're also using it to say, hey, let us turn around and warn physicians, don't you dare try to join one of these prepaid physician groups, or we will come after you. We will take your license, and you will have wasted all that time in medical school, and you won't have a career. So, a prestigious scientific journal, yet they still found room to threaten their own members, or maybe even physicians too who weren't members. So
why did they go after them though? Like, I have so many questions about all the other things you now said, but I wonder, why did they go after them?
Such a good question. And this is where, isn't it so funny when you look at the primary sources, how they tell you things you don't expect, and sometimes you try to argue with them, but hey, they were there. they made the sources. So this is where I was arguing with my sources, because the AMA has always been so well known for fighting government intervention in healthcare and fighting socialized medicine and fighting universal healthcare and healthcare reform. A lot of scholars have just assumed, therefore, they were pro-free market. I fear that sometimes historians read too much of our current day circumstances back. Like, they think Democrats and Republicans were the same, 120 years ago, and they're not. You need to understand that the issues were different, right? So what people do not realize about organized physicians is they were just as opposed to the free market or the competitive market as they were the government, maybe more so. And that was what, now some scholars have noted this. They talk more about the models they're against, but without coming out and saying, look, they were horrified about the idea that a physician would enter a competitive market and act and compete against another physician. To them, that was crass. That was dirty. That was for the lower sorts. They were experts. They were scientists. They were, right. And we see how all professions, we professors do this, right? We all, journalists, we all think very highly of our professions, right? Well, this is them putting themselves on a pedestal as well, saying we're not going to enter into that dirty marketplace and compete against one another. No, we snatch life out of the jaws of death. We're there for the most important moments. We're the scientists. We blend science and art. And how dare you suggest that we would just be like, a regular old store owner or a regular peddler. So they would call these prepaid physician groups like supermarket medicine, if that gives you an idea. Think also too about this period. You have the rise going on because you got kind of the second phase of the Industrial Revolution has been unfolding behind them. You have the rise of the large corporation. Yes, we're accustomed to them today, even though of course we criticize them a lot, but you can imagine how frightening this is for people seeing the world quickly be organized into corporations in these commercial units that are very large, right? Bureaucratic, almost seem faceless, hierarchical. The physicians are afraid of getting pulled into that. And that's a rational fear. They would look, for example, say if they looked at the profession of engineers and say, the engineers got pulled into the corporation, right? And what the physicians don't want to happen is to be answering to some union boss or something, right? To some manager, because they're pulled into the corporation. You have these healthcare corporations, right? You can almost imagine what they're thinking, right? And they become salaried employees who work for people who don't even know anything about medicine, but they work for them. So this is the fear they have, and they're very afraid that these prepaid physician groups are kind of like the beginnings, right?
Like the step before it, because the prepaid physician groups themselves didn't have that problem, right?
No, but they're looking at it as a nascent corporation because you have capital pooling, right? You have prepaid plans. They didn't like insurance either. They get dragged kicking and screaming to finally approve insurance because they're afraid insurance is going to lead to these healthcare corporations, supermarket medicine and stuff. And that physicians are going to have to compete against one another to get jobs or compete against one another very vigorously in the marketplace. Even where physicians practice independently, in their own practices, all the AMA ethics are against any type of overt competition. You can't say anything bad about another physician. You can't question what another physician has done. You can't try to take care of another physician's patient. I mean, or you will lose your license. You will get kicked out of your little local medical society and lose your license. And the thing about the AMA is as big as the United States is, they do have eyes and ears everywhere because the way they have their organization set up is really brilliant. They set it up to mimic the federalized system of the United States. So they have local medical societies on the county or city level. Then you have the state medical society, and that feeds into the national medical society. So you're going to have one of those little local societies somewhere, the eyes and ears of the Chicago headquarters looking to see if you're doing what you're supposed to be doing, right? And so that explains some of the power they had. But yeah, they're very worried about commercialization of medical care and healthcare, and them losing their autonomy, right? Working for non-medical people, being forced into a situation where it's very competitive and they're competing against one another, much like entrepreneurs, and business leaders compete against one another now. And insurance also, the other problem with that is even if insurance companies get involved, they don't like that idea either, because then the insurance company can start to get power in that market. But they do everything they can to shut down the prepaid physician groups, and they do a good job of that. They really do prevent them from going anywhere. I maintain that if it hadn't been for the AMA, that would have been the dominant model.
So basically they worked against themselves, because with the prepaid physician model, they would have kept the power. Of course, it could have gone further. They could have been right, but they had insurance with their hospital, so they wouldn't have needed that third party that now is very dominant, sometimes more dominant than an individual physician for sure, or a hospital.
Exactly. So maybe in the 50s, they still were thinking they were doing the right thing, but certainly by the 70s or 80s, if anybody's looking back, they have to see, wow, we did not, we didn't do that. If we were trying to not come under a third party's control, we did not handle that well. The best way they could have gone was with the prepaid physician group. But they were offended even that, like, in a prepaid physician group, this is another really important thing I need to tell you about the prepaid physician group that I didn't say to explain to you how even the individual was tied to the bottom line. The way they often paid the doctors was that you would have a set salary and then you get a cut of the profits. Now, of course, if you're a senior physician or you founded the place, your cut's going to be bigger. And the AMA didn't even like the fact that they would have different cut. But like if you're a junior physician, you're brought in, your cut is smaller. But that I think is really important for that whole point that I was trying to explain to you about walking that line between overutilization and rationalization. They care about the practice doing well and making making money, but they can only do that by practicing medicine to the high, with the best quality care they can possibly provide.
Because I would imagine that quality stifled because of this more and more control of the AMA, because if you're not able to compete and you're not allowed to say that someone is not a good doctor, then nobody is incentivized to bring quality about.
Yep. Yeah, it's a lot of backwards ways, and you can see too that can partially explain some of the medical malpractice mania we have. It probably didn't help the AMA overall to kind of keep that veil of secrecy around medicine the way they did, but they wanted to basically be treated differently. We see this a lot. Every profession is like, but no, we're the special profession that needs all the special. Well, I keep saying it because I think it's funny. Professors do it all the time, right? We're the ones who are, leading the next generation. And if you don't have us, everything is, so they're just doing the same thing that we would have done. So, but the problem is exactly like you said, the way they ended up going decades down the line, they lose massive autonomy. They're losing money. They're losing freedom to practice as they see fit. So I'll tell you a little bit about that story, how we get to where we are today. So if you look at, say you're looking in the 1930s approximately, you'll see a medical market with tons of different medical models. I mentioned union welfare funds. I mentioned the mutual aid societies and the prepaid physician groups. There were plenty of other models as well. There are farmers associations and consumer unions and all types of medical models.
Were they all able to coexist?
Yes, because it was just what the patient decided they wanted. And in some areas, for example, you might not have a prepaid physician group because you have a consumer cooperative, which is somewhat similar. It just might have a consumer board, or the farmers association elects a board to kind of oversee the package and the management and such. So you can see how some of these models are versions of one another, really depending on the region, because the United States is just so different and you have such different communities everywhere. So you have all these experiments and people are very happy with them. Like you see some of the reporting on it, even the academic research we have during the period going on. But of course, during the Great Depression, as I'm sure even your listeners probably know, that is when the United States government starts to become more involved in the economy, right? Because our national government had, compared to Europe, been a bit more hands-off about the economy, not completely, but more so, since that was more delegated to the states. So as they're getting involved in the economy, because of course, we have a worldwide Great Depression and they're wading into the economic sectors, of course, healthcare is, that's low-hanging fruit for reformers because nothing has been done. And where the private market's trying to develop, AMA is just going around and beating it up and destroying it. So, I mean, they really are their own worst enemies. Because later they're going to turn around and make an argument about how great the free market and private market is, but it's only because of the Cold War. It's only because they're being political. They don't believe that, right? They still do not think, doctors have any business competing in a marketplace. So basically in the 1930s, the federal pressure starts to come on. There had already been, in the 19-teens, there'd been some attempts to do some state level healthcare reform with some payments from the state government to provide care for workers in some cases. That doesn't happen in the 1930s, as you can imagine. Federal policymakers are looking at how they can create or provide federal funding for healthcare to make it more accessible. We have the big 1935 Social Security Act. That's kind of the foundation of the welfare state in the United States. Healthcare is very much talked about. The people who put that bill together very much want to put healthcare funding in it. President Roosevelt, being very astute politically, says, no, I'm not trying to sink my entire bill, because of how he knew the whole thing would be sunk if they put in healthcare, because he feared going up against the physicians, because he knew how they were organized. He knew the AMA, he knew how powerful they were. He's just, whatever you may think of Roosevelt, he understood politics, right? He really did. So, but yet the concern is there. He creates a technical committee. There's a national conference. There's finally legislation at the end of the 30s is introduced in Congress for there be federal funding of healthcare. So you see all this stuff is going on, right? And the AMA leaders are getting more and more nervous. They're getting extremely worried because the economic interventions that are done in the 1930s in the United States are very significant, right? Very different from anything that had come before. And so they were looking at reading the writing on the wall. So amidst all this pressure, they kind of buckle and say, okay, we will compromise. And what their compromise is of course, they still don't want any federal funding or involvement in the healthcare market, but they say, but we're going to allow health insurance. We're going to stop trying to defeat health insurance, and we're going to stop revoking every physician's license who accepts health insurance or is involved in health insurance. And so you're thinking, oh, well, that's good. But no, it wasn't even as good as that. It wasn't insurance so much that they were accepting. Yes, as 1938. What is so interesting about it, if you study the episode, it's a very, very specific kind of insurance. It's a very specific model. So basically what happens at the end of the 30s, they just invent our healthcare model, which is still the healthcare model we have today. And it's so inefficient, and it makes no sense. It had never existed before in the marketplace, which tells you it's inefficient and it isn't a good idea because the market hadn't come up with it yet. So this is hilarious. What they do is they say, okay, we're going to accept insurance, but none of these prepaid physician groups, no union groups, no consumer cooperatives, no mutual aid funds, none of that. The only insurance that we're going to be okay with is insurance through insurance companies.
Third-party payers,
because they're thinking, hey, they're located in one building, right? Headquartered somewhere. It's easier to deal with them if we're spread out all over the United States and they're just way far away over there. We can keep them out of our business long enough. At least that was the thinking. That's
great thinking.
Right.
Oh no.
So that is the kind of deal they make, is then they say, okay, fine. They very begrudgingly say, this is the insurance we're going to accept. They're very specific about it. Everybody else is still getting run out of town. Everybody else is still losing their license and getting smushed. So this is what they do. They take this very specific model. It has to be insurance through an insurance company. The insurance company has to pay us fee for service. They can't pay us payments, which, as you well know, a capitation payment would be a set fee per patient in the plan. It could be quarterly or annually or biannually. And of course, that incentivizes the provider to budget and think about care and not try to overutilize. But the AMA says absolutely not, no way. It certainly can't be salaried or anything like that. The other rule that the AMA attaches to it is that the insurance company better not even question what the physician did, right? Absolutely not. So the way it starts out is great for physicians.
Yeah, I bet. This is a way to make money.
Right. Oh, yeah, man. Practicing in the 50s, you would have been making money hand over fist. But that's not going to last long, right? Because they're going to create a system that is very problematic and is just going to keep crying out for reform. So this is what the AMA hilariously does. They come up with this crazy, I don't know, Hydra monster, horrible thing of a healthcare insurance model. They call this the free market. Hey, everybody, here's the free market. And if you try to do anything else, we're going to, take your career away and get you fired. But this is
very free.
Yeah, exactly. So you can see how, then as we're coming out of World War II, right? And there's a big push in the United States for universal health care under Truman, because Roosevelt, had kept it alive, and everybody's looking at what's going on in Europe. And, we're always worried about keeping up with Europe. So everybody's looking over there. And this is the AMA with their really horrible model saying, no, this is the free market, because now the Cold War setting in. And so now they're going to set it up as a communism versus free market issue, even though that's not at all what's going on. It's just to sell it, and it's just for political reasons. So basically what happens is, with Truman stumping to get his universal health care plan passed. And as I mentioned before, a lot of the reformers, the way they wanted that plan to be set up was they wanted to kind of go back and recapture those prepaid physician models. There were some other things they wanted to do too. I think they were also enamored with some of the nonprofit insurers like Blue Cross, but they were still enamored too of the prepaid physician groups. But the way the AMA ran that entire campaign against the Truman Bill was that this is communism, this is socialism. What we're trying to give you is the free market, but that was an absolute lie. This model, I call it the insurance company model that the AMA comes up with, this very particular weird thing, is what they then run with. And then what ends up happening is, in order for them to prove that this model is everything that they say it is, right? Oh, the glorious thing is, then the AMA actually ends up aligning itself with insurance companies and trying to expand this model as fast as possible, because they want to be able to keep going to policymakers and say, we don't need healthcare reform. Look at how many more people we've covered. Look at how much of the population we've covered. Look at how the market is doing it. And again, with the Cold War backdrop, this is a very powerful political argument, right? When you're saying we don't need the government to intervene, the market can handle this. But the market couldn't handle it because the model was so inefficient. So, and everybody recognized this. The physicians recognized it. Insurance companies recognized it. The insurance companies did not want to get involved with this. They get involved because they're not dumb, right? They're business people. They're looking at the AMA model saying, are you kidding? You're pretty much just asking us to write you a blank check, right?
That's true. Fee for service, like if you don't control that in any certain way, like physicians will just increase their income until they reach their target income. It won't affect
exactly. And that's why too, even distribution becomes a problem, because you can't get physicians to go out to rural areas where they can set up whatever city they want to be in. And even if it's an oversaturated market, fee for service will get you to the salary you need to get to, but nobody will ever go help the poor people in the rural areas or the more inner city areas or stuff where it's hard for them to get physicians. So that it's a big problem. Basically, what they end up doing is just running as fast as they can to expand this model. But the insurance companies, for political reasons, end up giving in. They did not want to write this insurance at all. It's neat even being in the archives with some of these big insurers and seeing memos and stuff from the 1930s. And like the business is going to them and saying, will you write a health insurance policy for our workers? Because say they're trying to keep down unionization and they're trying to beat back the labor unions, and them saying, no way, no thanks. We are not trying to get involved in that. They again, they're not stupid. They don't want to be, even if it hadn't been on the AMA's model, they were worried about it because they had tried with some accident and loss policies that didn't go well already. So they kind of get dragged into it for political reasons. And this is basically what happens is they decide we need to help the AMA defeat socialized medicine, even though we're just insurance companies, because the idea coming out of World War II particularly is that if the healthcare system is socialized or reformed, or we have a universal system, that'll set a precedent that'll carry over into all the other sectors. And then we'll end up turning more like European welfare states and end up having heavier governance. So there's this idea in the business community that you have to protect the healthcare sector. It's that domino. You have to keep standing, because if it falls, it's going to knock all the other ones down, and introduce more nationalization, more heavier regulation, heavier government intervention into every other business sector. That's just what they're thinking. And so that's why
they agree, because it doesn't sound like it favored them in any way. If you don't get a choice but to pay the physician, no matter their quality, no matter whether you know what they did or not, that doesn't sound like something you easily agree to as a whole sector.
And that's a good point. So you've heard of the frog who gets boiled alive, because you don't put a frog into a boiling water. You put the frog in the pot and the water's normal, and then you turn up the heat and the frog just doesn't know. And then they're cooked because little by little by little by little. The same kind of thing happens with the insurance companies, because when they first get involved at the end of the 1930s, it's reluctant. And the policies they're writing are so, you would laugh if you saw them. They are so stingy. They're so tiny. They're so like, well, we'll cover you only if you go to the hospital. And only if it's like these 10 to 12 diseases that we're going to list in the policy, and nothing else, and an accident, and we'll cover 60 to 80% of the bills. I mean, it's very little coverage that you're getting, right? Because of the very problems that you mentioned. So that's the way they start. And then they're giving these very meager insurance policies just to employee groups, which are going to be healthier than, right? Are going to be healthier than groups that aren't working, for example. They're going to be healthier than, say, the average population if they're working. And they'll be union workers, right? They're certainly not, they don't have maternity benefits or anything like that. Now, the prepaid physician groups did, because they were run so efficiently that you could give the patients all the bells and whistles and all the coverage and all the benefits. But because the insurance company model was not efficient, doesn't have any economic logic to it, you can't. You have to have very, very stripped down policies. So that's how they start. And they get pulled in little by little by little. And then once you're in the insurance companies, think about it, then they set up the healthcare division. So then you have executives who are kind of bought, and that's their little fiefdom, that's their little place of power. And so they have incentive to see their side of the business grow. And you can see little by little by little, even though all the way through, even into the early 60s, you see a lot of these insurance companies losing money and subsidizing the profits of their healthcare underwriting with profits from like their life and casualty lines, because of political things they're trying to do. At one point at the end of the 50s, they're making a big push to try to say we can cover the elderly so that we don't get Medicare in 1965.
No.
They try. And what happens? They're just like, they try it and they're like, we cannot. They even go so far as to get enabling legislation to allow them to pool all their administrative resources and even some assets for insurance companies to come together as groups to try to insure the elderly. And they can't do it. They are losing too much money.
So that is because it's fee for service, because they don't get a choice but to pay no matter the cost, no matter the procedure, whether it was justified or not.
Yeah. And those elderly policies were hospitalization only. They weren't even able to give them medical. I mean, those were stripped down, even though by the end of the 50s, early 60s, your average, say, union worker would have had a much better policy. Even when they're trying to cover the elderly, they could still only give them stripped down policies. So of course, if you look at US healthcare costs, when the insurance company model starts taking off, it's really going to start taking hold at the end of the 1940s. That's when you see the year-to-year costs start jumping up and increasing and being higher than any other increases. If you look at the different categories of consumer goods, if you're thinking, transportation, housing, energy, and such, start jumping up at much higher rates and then never go back down. That's when it just starts, you can see, getting out of control. And for those in your audience who don't know, there's clearly a problem with pricing, with costs in the United States with our healthcare system, because probably a lot of people know that we're the number one spender, which might not be a problem, right? Say we're just a wealthy country and we have lots of money to spend on fantastic healthcare. That might not be a problem, but you can kind of see there's a problem even just looking at the raw numbers, because we don't have a universal system. It's great for some people, not so great for others. We know we have the problem with fragmented care. And then you add in the fact that we are close to 1/5 of our total GDP being spent on healthcare services. And when you look at the second place countries, they are so far behind. They're not just behind us. They are like 8 points, like say we're getting close to, say we're around 19-20%, and the second places are back around 12 or 13. So you can see something's not right.
Yeah, and also your life expectancy is not the highest, because if your system would be that good, your life expectancy was supposed to also be that high, right?
Yes, but I would push back on some of the statistics. How you can do things with statistics. There are a few things with United States statistics I see regularly trotted out about our healthcare that I do laugh about.
Okay,
if you think Cuba has a better healthcare system, they don't. No, I'm not saying you do, but I'm saying to your audience. That's why I'm kind of laughing. So with statistics, we do have a decent healthcare system, right? as I was saying, it's really bad for some, but even like, say you look at infant mortality, you'd be surprised how unreliable that statistic is.
How
In the
is that?
United States, it's culturally how you count statistics. This is so fascinating. In countries like Belgium and France, they don't quite count a live birth like we historically have. We'll count almost anything as a live birth. Whereas in other countries, even in Europe, you would think this would be a problem mostly in, like, say, underdeveloped countries, where they're like, the baby only lived a few hours or a few days. We're not going to count it as a live birth. They just don't. Culturally, they just don't. And it probably too, I'm sure if you did a really deep dive on this, if you dove into each country and looked at the history of how they count those statistics, you'd find social, cultural, and political, because say something about the hospital's funding is tied to a number, right? Something about the way the physician gets reimbursed is tied to a statistic. Right. And so these things get corrupted. And it's just, you have to really understand what goes into that number to understand whether or not what it's really telling you. And the United States, the way we count it, it ends up looking like we have a horrible infant mortality rate. And we do amongst crack addicts and drug users. But that's a different problem. That's not a healthcare system problem, right? So that's why I will push back on some of those. And there was another one also too. Yeah, then you have to kind of look at social issues too sometimes when you're then starting to look at other issues like drug use, suicides, and other things. But so that's where some of this whole, their mortality rates aren't so good. You really got to kind of dig into those numbers to see how true that is. So that I will just give you a little note on.
Interesting. Yeah, that's good to hear. That's so interesting. So the push for universal health insurance does in the end come to the US or to the US system, but it never goes through?
Yeah, so it doesn't go through. I would say until we get, of course, to under President Obama and the comprehensive reform that passes in 2010. But when we get there, you'll see that it's like, they just kind of they just patched up the system we already had. But the last big push, I mean, there's a bit of a push in the 70s, but the real big one is at the end of the 1940s with the Truman Plan. I think what is interesting, and again, this is something scholars hadn't looked at before, they would kind of look at the big reform episodes, but by ignoring a lot of the, I guess, less sexy, not as exciting things that were going on in between, they missed a lot of the very significant things that happened. Like, so I was telling you how I was surprised when I was looking at the primary sources to see how against the private market or competitive markets physicians were. Another thing is you would often see in the literature people saying, the doctors, they defeated the Truman Plan, and then everything is great for them and they don't have to worry about anything until the Medicare push in the mid 60s. And then I go and this is why I love being a historian and that we have to work with primary sources, because I got to look at thousands and thousands of pages of, board of directors meetings of insurance companies and inter-office memos and trade association papers. And even I had a lot of AMA internal documents and papers and committee meetings. And even some of their correspondence and arguments. And so it was just really fascinating to be able to see what was going on. And one thing I was saying is, why are you guys so nervous about healthcare reform? Don't you know Eisenhower's in office and everything is great? Because I'm trying to make them conform to what I thought they should think, right? Because with my hindsight. So, of course, they didn't have my hindsight. So what's so interesting is even though Truman's bill gets defeated, and then Eisenhower, who's a Republican, is not going to push for universal health care, he comes in, he's pushing healthcare reform anyway. He doesn't want to do it the way Truman wanted to do it, right? That's too radical. But what is amazing is all through the 50s, Democrats and Republicans are all trying to reform healthcare. Well, that doesn't make sense. Why are they all trying to reform healthcare? Because the point I figured out is everybody recognized that this insurance company model was a disaster. Republican, Democrat, everybody knew it was a mess and they had to do something in order to be able to expand coverage and such. So for example, Eisenhower wanted a reinsurance bill, which pretty much he was saying to the insurance companies, hey, if you guys go and sign up more people, even if they're sick, because of course insurance companies don't want to insure sick people. If you insure more people, even if they're chronically ill, and you give them tons of benefits, like, that they have all their labs and all their medical bills covered and most of their hospital and everything, if you do that and you lose money, the government will reimburse you, at least for part of your losses. That is, we kind of see that with like our or mortgage market where bankers can get reimbursed if they lose money on mortgages. So he's trying to do a similar system with healthcare. That doesn't go through, but I think it's just so interesting that there are groups, there are bipartisan groups in Congress, there are groups of Republicans in Congress, there are groups of Democrats in Congress, all still trying to reform the messed up healthcare system. Meanwhile, physicians and insurers have partnered and are running as fast as they can to cover as many people as they can, recognizing that if they can do that, they're going to force all the institutions in the healthcare market to develop around their insurance company model and ensure its legitimization and ensure that it's embedded, within the heart of the healthcare system, which they do end up doing.
Why? Why did no one say, guys, we messed this one up? Let's change to another system? Why did they keep running with a broken system?
Because once you get rolling on one thing, I mean, what are you going to do? Go back and say, oh, we should have had the prepaid physician groups? Because especially too in the 50s, where you have to think for the average physician, it's working out really well. I mean, they might be worried politically, the leaders might be, but if you're a physician, you're just billing for about anything you want. In fact, one of the things I uncovered too, and then actually Nancy Tomes ends up writing about it as well, is that there was an unnecessary surgery crisis in the 1950s, as you can imagine. Right? All these, healthy appendixes are getting taken out of people and tonsils and all, because again, fee for service, you're not allowed to question us. And this is where you just get pure, straight up unethical physicians. These are bad actors who are going to make, of course, all physicians look bad, but you just set up a system that dangled all the carrots in front of them and begged them to act badly, right? You just did you just incentivize bad people to get into medicine and to start just doing unnecessary surgery. So this is
even incentivize good people to turn like less good or bad just to make ends meet.
Right. Well, you can't question the doctor doing the fraudulent things because he's probably, an officer down at the local medical society. Right. And that was one big thing about those local medicals, that they're just good old boys clubs and a medical society. And don't you dare question one of us. So you can very well see how that's going to play out. And every little city and every little county is going to have their own particular set of the good old boys, right? Doing what they want to do. And don't you dare question them. In fact, don't you even dare try to charge less. They'll boot you out for that because you're trying to compete with them by lowering your prices. How dare you? Right? Yeah, I know the nerve.
It's just so crazy.
So yeah, they're not going to want to jump back to the prepaid physician groups because it's working very well for the physicians who are just practicing this way. Now, it's not going to. What's happening in the 50s, because the prices are jumping so quickly, and you can imagine the insurance policies, even the prices of that they're giving to the consumer are going up 10, 15, 20% year to year. That's crazy price increases on things, especially when you're in an economy that isn't going through hyperinflation or, So not to say we didn't have any inflation in the 50s, but not to that degree. So they're just focused on expanding the model, really. But what's starting to happen is now they're starting to have a political problem because the prices are going up so much. So the doctors have to reluctantly start letting the insurers do a few things to kind of a little bit monitor and supervise what the physicians are doing, right? So you can see how little by little the insurance companies are needing to start setting up the institutions to monitor physicians. Now, the hilarious fights I read, the arguments they're having in the 50s and the way the insurers are just cowering to everything that the physicians say. Of course, by the time, we get to today, I would say that's kind of more reversed. But so in the 1950s, here's an example. Because of all these problems with the unnecessary surgeries, that hits the media. It becomes it's bad publicity, bad politics. How are you going to, here AMA leaders are saying that the so-called private market, the insurance company model is doing such a great job, but then there's this huge problem. So the physicians have to reluctantly agree to allow hospitals to set up, they call them tissue committees originally, so that they can test the tissue of an appendix or an organ that's removed, like hysterectomies and stuff, to see if it was diseased or not. And you expect a certain percentage, maybe 10%, maybe 12% to be healthy. Like, oops, we thought it was appendicitis, but it wasn't, and that would be normal. But you don't expect 50 to 70% to test healthy, right? So that's why they call them tissue committees, because the pathologists would test some of the so-called diseased organs that were taken out. But then what they become are utilization review committees. And these are committees that are set up in hospitals. Physicians have a heart attack about it and insist that they have to be populated by almost all physicians. Sometimes there'll be like a hospital administrator on it, but the insurers aren't allowed on it, but they're set up for the insurers. And they're going to become more and more important and larger and larger. They're going to be monitoring what physicians are doing. These utilization review committees are going to start deciding how medicine should be practiced. They're going to start standardizing it. They're going to start making charts to the point today where that's the way physicians practice medicine. They are often handed a treatment blueprint from a corporation, from an insurance company, and said, if you want to get reimbursed, you need to follow this treatment blueprint the way we say to practice medicine, not the way you say to practice medicine, the way we say to practice medicine. And this starts with utilization review committees looking over their shoulders, then giving them standardized ways that they're supposed to treat every patient, and then collecting data from the hospital and from these patients, and then feeding it back to the insurance companies. So the insurance companies, starting in the 50s on out, are themselves, insurers are now having to become experts in medicine, right? Because before they were life insurers, casualty insurers, but life insurers, they have mortality tables, but people die only one time. So figuring out the statistics on that, right, is a lot simpler than morbidity, right? Like how many thousands, I think the original morbidity tables over 3,500 different illnesses or diagnoses, and right, and how do you treat, and yet they're going to find a standardized way to handle each one, and they're having to put more rules on physicians, more controls on physicians, in order to play this cat and mouse game of not having them overutilize or bill pad. There's a number of things that are going on with fees that I won't get into, but they're starting to standardize them more. Still fee for service, but at least they're standardized fees and not just whatever you make up. So then it's starting to be, okay, now physician, you need to get our permission to admit that patient to the hospital. Okay, now you have to. So you see how they're getting more and more rules and regulations. I would say this is happening within, between the 50s and the 80s. You see more and more and more rules being put on the physicians. Of course, they're mad about it and arguing, but it has to start because it's such a big political problem that healthcare prices are rising so quickly. And for all the different cost containment measures that they come up with, notice how none of them ever managed to really fix the fundamental flaws of incentives being misaligned. And it really is just a cat and mouse game of them figuring out how to get around whatever the newest regulation is. And so it hasn't really worked. So there's been a lot of attempts. So we have this insurance company model, basically what happens. And then our big, most significant reform in the United States in the 20th century, before we get to the 2010 comprehensive reform, is Medicare in 1965. And what is so significant about that, as far as the insurance company model goes and the way our system is set up, is by the time we get to that point, you still have a lot of the same reformers who were around maybe for the Truman battle, and still like the Social Security Administration, a lot of labor leaders and people who were interested in health and welfare issues, who had been trying to get us back to, say, the prepaid physician model, some of those more progressive models, or more interested in nonprofit models. But by the time we get to the 60s, because the Medicare debates are really heating up by the end of the 50s and the early 60s, they're saying, as much as we wanted to get rid of this insurance company model, we're just not going to be able to do it. I mean, all the institutions are set up this way. Hospitals are set up this way. Doctors are set. All of the overlapping institutions that that these medical providers have forged with the financiers, the insurance companies, the processes, the utilization review committees, the way they do the billing, everything has been, the tables, everything's been set up. And not only that, this is what our voters and our citizens are used to. And if we try to have a healthcare program for the seniors that's different, that looks different, it's not going to be as popular, right? Medicare is a very, very popular welfare program. It passes with bipartisan support. Even people who didn't vote for it, almost everybody supported an alternative, just another kind of Medicare program, right? So it was very popular. But what's so important is that they're saying, yeah, we're just going to build it right on top of the insurance company model. And that's what they just plunk it down on top of that. And you know what? We're just going to have insurance companies manage the program. So insurance companies become that go between the federal government government and the hospitals and the doctors. And that way they can use all the processes and the institutional pathways that they have already set up. They can go ahead and use that. And plus the beneficiaries, the elderly, those over 65, they'll be able to interact with their physician and hospitals like they always had, right? It'll look normal to them. But that's just very important, because then it just kind of naturalizes the insurance company model. It makes everybody think that it's just this thing that naturally arose out of the market. And this, because the AMA all throughout the 40s and 50s is arguing that this is the so-called private market or voluntary market, and this is the American way, the answer to socialized medicine. But that's not true. But everybody just kind of buys into it. They forget, right? Memories are short. So with Medicare, you have this naturalization of this very strange economic model, and it just gets forgotten. And then everything after that is just an attempt to bandage. And you can see, it's almost kind of hilarious to see the way they're kind of band-aid it up. In the 70s, they have some reforms that are kind of trying to recapture the prepaid physician groups, but you almost have to laugh because they're trying to do it with the insurance company model. And it's a very clumsy way of doing things. They don't quite get that. No, you still don't have the doctors have to be incentivized, that they're tied to the bottom line. It doesn't work if you just have a prepaid physician group, but they're all on salary. That's what Kaiser Permanente, that's a prepaid, that's we still have that, but that's not the same thing, because physicians on salary, that's a prepaid group run by a corporation, not run by, physicians don't run it and manage it, and they're not tied to the bottom line. If anything, they just get salaries, and they actually get bonuses based on how much care they'll withhold. So that's the way they're incentivized, right?
So that's incentivizing less care instead of enough care, like undersupplying care.
Right. And that's what they'll do, because they just get a basic salary, and then they'll get a memo or something saying, hey, if you do less of these procedures, you'll get this much of a bonus. Or if you get so they're not tied to the bottom line. It's a corporation that runs it, right? So there were these attempts in the 70s to pass legislation to encourage to go back to what we had in the 20s and 30s, but it's a very ham-fisted way of doing it. They're just, again, trying to bandage up this broken insurance company model. And as long as that broken insurance company model is there, there's just not much you can do for making sense of things. You're going to have the problems with fragmented care, and you're going to have the problems with costs running out of control. So for your people who don't get their benefits through their employer, which is the way it mostly works in the United States, if you have an employer, which again, think of how much that messes up the market. Think about if everybody in the United States assumed, well, I'll get my car when I get my job, and I'll get to pick either a Honda Accord that's blue or a Toyota Camry that's red, right? And I don't get to pick what the stereo system's like, or the cup holders, the leather seats, or the regular seats, or the sunroof. That's what you get, right? So just think of the medical market is so messed up that when you get your job, it's, well, I hope my employer picked in a good insurance company. And if you work for a really good employer, you might have a choice of 2 or 3. If you're a government employee and you have great benefits, like I do, because I'm a state employee as a university professor, you might be able to choose between 2 or 3 packages. And usually we do actually have good insurance, but you see how that's still going to mess it up, because you don't get to pick from the full marketplace of potential. If you're saying, oh, actually, this is better for me, my family, we have a lot of for example, we have a lot of mental health problems running my family, and nothing's wrong with me now, but I want that extra insurance just in case. So I'm going to pay for that. But the person next to me doesn't want to pay for that. They want to pay extra because they want to be able to go see this physician who's out of network, or this person, everybody has their different concerns that they're concerned about. But, basically it's, you get this and that's what you get. But it still tends to be pretty decent, good health insurance. But you can imagine those who are on the outside of that employer provided system, they just can't afford insurance because it's so prohibitively expensive. The hilarious thing in the United States is you have all these people walking around who think that their health insurance costs them $100 or $200 a month, because that's what they pay out of their paycheck to their employer for, say, their family's insurance. They don't see the $35,000 of salary that they don't have. And that is what it is. And employers do not hire people based on what their net or even their gross salaries. They're looking at the total cost of employment, which in the United States, fringe benefits is a good 35, even 50% of your total compensation. So, that's a lot of money that you lost, and people just don't realize it, right? And so even though our healthcare is so expensive, people aren't really, really stressed about it because they're taken care of.
Well, they think they're taken care of.
Think they're taken care of.
You get to pick the package? Do you get to pick what's in it? If you only have one health insurer that your company is with, you don't get to pick what's in your health insurance and what's included, right?
Yeah. And also it's just been, even at the state level, it just started to get legislated. I mean, healthcare is such a political football. What happened is you started to have, this is kind of funny. Politics. What happened is you started to have every group going down to the state house to lobby to pass a bill to require insurers to have whatever coverage, right? The chiropractors, you need to require the insurers to cover the acupuncture, and I might have some sympathy for some of this because I like going to see my acupuncturist, right? But you have to also kind of laugh because you can see where this is going, right? Everybody's thing needs to be included in. And I think people have a hard time separating what's necessary from what would be nice. And you even see this with the ACA reform under Obama. What's required, the required insurance that you have to buy from the exchanges is ridiculous. They won't allow anybody to have a basic package. And so it's like, okay, but then I have to pay more than a mortgage payment for my family of 4. Like, can I get something cheaper? Nope. You will take, gold-plated benefits and you will like it, right? So that's easy for us, elites to say, or people who are used to having the best of the best, but it may be not the best way to handle healthcare, is just to force what looks good on paper. It can cause a lot of problems in the real world. That's a big criticism, I would say, of the exchange. The insurance policies they sell on the Obama exchanges is just by law. They have to be these gold-plated packages. So, I mean, I know they're gold, silver, platinum. They say that, but I'm saying the lowest down one is ridiculously gold-plated is what I'm saying. It's not a basic package. Actually, okay, I don't want to go into that too much, but that actually ended up hurting the individual market in a lot of ways that we didn't realize it was going to do. But so you can see how with our system, it became so bad that we didn't have a universal system, because if healthcare is that expensive and you can get it when you have a good full-time job, well, then you have people who are the working poor. So they don't qualify for Medicaid, which is for poor people. Medicare in the United States is for the elderly. Medicaid is for poor people. And they don't have a good enough job where they have this super expensive insurance. And they certainly don't have enough money to just go out on the marketplace and buy it. Although that individual market was developing a lot before the ACA was passed, it's still, you can see how it's going to be so expensive because you're not working with an efficient model. So this is how we created all these issues, and that we keep trying to band-aid it up, but we don't ever actually go in and change the model. And again, you can understand why all these institutions are built up around it. This is what everybody's accustomed to. This is the way it's always been done. So
except that that's not true. That fascinates me, that this is the way it's always been done, except that that's not true. But I was wondering, so at the moment, it's not mandatory to have health insurance in the US then, right?
Right. So this is another problem with the ACA. The way it was written, because they passed it so quickly, and they passed it with only one party support. It wasn't like Medicare, right? Very controversial. It was, the way it was passed is just not the way things are usually done. So it didn't ever look very legitimate to a lot of people, the way Medicare did, the way Social Security did. But because of that, the way they were trying to pass it, they had to put the language as very as determined by the Secretary of Health and Human Services. And they just say that over and over and over again. So they kind of passed this bill that is so ambiguous that it almost just depends on who the president is in office. It's going to I can tell you, it's going to go back and forth and back. That program is not going to be stable because of the way the legislation is written. Now, of course, every president and the executive branch, whenever they come into office, they're going to change, it's going to be felt across all policies. But I am saying with the way the ACA is written, far more significantly, they're going to be able to change the way that program looks depending on what party's in power, or even then what specific president's in power, and if they even care about the issue or not, or what they want to do. So that's still a program in flux, even though it's our big comprehensive healthcare reform from 2010. We still don't even know what it's going to look like next year. So
Oh my
because
goodness.
Trump did take off the mandate, right? Which I think is, I mean, we were mandating people to spend more than a mortgage payment with a private corporation.
Mm.
I mean, it was really sad. And I really wish people had talked more about how bad these expensive these state exchange policies were. People were paying, if you're paying like a mortgage to get health insurance, the same as you are for your mortgage, and then you also have to meet a $3,000 or $5,000 or $7,000 deductible before your health insurance even kicks in for the year,
Oh my goodness,
not for
that's so
over for the year.
much.
Are you really going to think that maybe, aren't you going to think I just shouldn't buy health insurance? I mean, I know a lot of people, especially self-employed people, like contractors, paint, people like that, who are just like, I did have health insurance from like some of them had little basic policies that they had bought individually, but the price just went up because then it was like, nope, now you have to buy this really nice policy. Aren't we so good that we're making you buy this really nice policy? Oh, well, thank you. You're not giving me I mean, yes, subsidies came along for some people, but for some people, no, right? And even if you have subsidies, it's still, people were shocked at how much they had to pay even with their subsidies, right? Because they're seeing the healthcare costs that those of us who get it through our employer are just blind to. Those silly people who are saying, oh, I only pay $100 or $200 a month. No, you're paying thousands and thousands of dollars a month. And so if you're paying that out of pocket, you can imagine why being forced to buy that really was a kick in the teeth for some of the working poor. They might have gotten more subsidies, but then just like kind of middling working people, right? Like I said, a lot of the self-employed folks, you can see how that has made things a lot more difficult. Again, looked good on paper, but this is the way a lot of it has come about. And it was because when they were trying to push through the ACA, people did want to, again, upend the insurance company model. There was an attempt with the public option. They were trying to put in the public option because they kind of wanted to make a more, they were hoping that eventually that would lead to a more nationalized system where they could get rid of the private insurers altogether and have everything managed through the government. And that it was that was not going to fly politically. So they didn't get that in. And instead, they just took the insurance company model again and built something on top of it. And so they had to deal with all the problems and inefficiencies that were already in that system. And so that's why they have these problems.
So an argument, I guess, against that could be, I don't know if they made that if everybody is insured, it kind of, the low risks even out the high risk, so the cost could lower overall. But that didn't happen because it sounds like because it became mandatory, the insurers just upped the prices.
Yeah, even when it was mandatory, some of the young people were just, it wasn't helping nearly as much as they said it was. First of all, young people were covered under their parents' policies anyway, until what, I think, was it 24 or 26? I can't remember what. Since they were covered so long under, that kind of undercut that idea that you'd have all these healthy 22-year-olds out there paying thousands of dollars a month. Really? You think you're going to get, for what? For when to them, they think they're invincible and they don't even understand what's the big deal with healthcare, right? They're not as concerned about it unless they have some chronic illness. So the whole idea that was going to work to begin with was false. Okay. That wasn't, the numbers weren't going to work out the way they wanted them to, that all these healthy 20-year-olds were going to spend. The idea would be spending thousands of dollars a month into the system, but not really using it. And then eventually, but that breaks down because people were just saying, we'll just take the tax penalty anyway, because it's still less than being forced to pay thousands a month, then meet thousands in a deductible in some cases. Now, the packages look different from state to state, so I can only give you generalizations and can't be super specific because, but those are just some general trends we saw. So then under Trump, he just took away the mandate, which I'm glad he did. I think it just, because you were penalizing the very people that you said you passed the reform program to happen, but because they're not complying the way you say, because they're getting crushed. I mean, I've seen some of the numbers and you can tell me it's anecdotal, but for whatever reason, it's not getting a lot of press. Well, I can guess why, but it just, we're crushing the very people that we say we want to that we want to help. And now again, of course, with the Biden administration in, again, it's up in the air and it's in flux. I mean, we saw a lot of talk of, just with a budget bill, talk that we're going to change the whole healthcare system again. And again, you can see because of the way that ACA legislation was written, anything, who knows what's going to happen in the next 5 to 10 years. So
is health insurance then a right? Is it something everybody should have? Because it worked in the prepaid provider model and the prepaid physician model. It doesn't work in the current system. Is it a right? Is it a privilege? What do you think?
Do I mean, because that's not an economic question, right? That's kind of a social or a political question. I think I am a little confused. The whole thing with healthcare being a right, and I know that's a political reason people say this all the time. I don't know that it necessarily helps. I mean, people can scream it all they want, but it's like, okay, well, food's a right, clothing's a right, housing's a right. What are you really saying? All right, love is a right. I mean, what are you really saying? To me, I don't like those kind of ambiguous. What does that mean? If is it a right, you have a right then to go grab all the doctors, put a gun to their head and say, get over here and start providing medicine. Is that what it being a right means? Because so that's, and also that's my personal opinion, but most healthcare scholars and researchers are going to say, yes, absolutely, it's a right. Okay, so just so your audience knows, I am definitely on the margins. Every other person you interview is going to be like, yes, it is. But I'm just saying, I think that's just political speak that doesn't mean anything. And then like politically in the US, you just see people saying it is. And I guess that's supposed to be shorthand just for this is what I believe, but also politically, it's going to scare a lot of people on the right. Right. So I think there are ways we could reform healthcare comprehensively without having to completely roll over people who would be worried about universal health care if we show them, make market and economic arguments and arguments about efficiency and effectiveness in a language that they could understand and like, oh, okay, we get it. You know, if you explain to them, look, this isn't a private marketplace. You're not protecting if you care about, like you say, you care about capitalism or private markets, fine. But just know that that's not what you're protecting. And if you can explain that to them, can you see how you're going to get them to come along instead of just screaming at them or, with your bumper sticker or your sign, it's all right, it's all right. That's just going to, but especially too, with all the, the upheaval we've had in the United States too, you can imagine we're very divided that you're just going to push a lot of people away. And I want them to listen because I do think there are ways that we could reform the system that would make progressives and people who, are more interested in competitive markets happy. Again, looking at those prepaid physician groups, customers were happy, physicians who practiced in them were happy, progressives obviously were happy. I do think we can do something like that.
How though? Like, where do you start?
One way is just that doctors have actually, because of everything that has been happening with healthcare, doctors have just kind of been they're so fed up with working for the insurance companies pretty much, or they're getting swallowed up by hospitals, right? They can't practice. They're having a hard time staying independent. It's too much work. It's too much paperwork. It's too much to manage with the financing, with the insurers and the hospitals and the this and the that. So they're just getting swallowed up, getting into their supermarket medicines that the AMA was trying to avoid all along, right? So a lot of them are just getting so fed up that they're just not taking insurance and they're starting to create prepaid physician groups again. However, right now they are still primarily single specialty. They're primarily general practitioners. And it's taking a lot of legwork for them to do this because they have to go state by state, again, because of the way the United States has our governing power split between the federal and the state level. They have to go to states and get laws on the books repealed from back in the 20s and 30s, where the AMA had them put laws on the books against the corporate practice of medicine.
Oh my goodness.
Laws that the AMA had passed even to get rid of prepaid physician groups and stuff. So they're having to, and because think of all the legislation and regulations that have been built up around the insurance company model. So they're having to go to state houses and kind of clear a way, and even sometimes to the federal government to clear a way through the regulation to be able to set up what are like prepaid physician groups. Like I said, they're just really mostly right now GPs. And I'm like, oh, they need to push there's a piece that they need to figure out. They need to figure out what they're going to do with hospitals. I know what would have happened if they had taken off in the 20s and 30s, but now they have to refigure out how they're going to get admitting privileges and how they're going to negotiate with hospitals. But they are popping up everywhere. There are already hundreds, if not thousands of them. And the way I often explain it to people is we had a movement here became popular called concierge medicine for the wealthy, who would also skip over, they would probably have insurance, but they would skip over the insurance company and pay a physician a lot of money, no insurance, and just concierge medicine. You spend a whole hour with me. You spend time taking care of me. We don't deal with the insurer, but I spend a good, well, obviously most people can't afford that. And so I call these new ways, I'm trying to remember what they call them, these new prepaid physician groups. I should have looked this up. I'm trying to remember what they're called, but it's kind of like concierge medicine for Joe Sixpack for the regular folks, because you pay a monthly fee to them, and they're actually now providing prescription medicines for pennies on the dollar of what people can get elsewhere. They're figuring out all kinds of ways to bring down costs. They're figuring out all kinds of ways to help to be creative about having more phone calls and computers and emails and getting on. And they're just spending a lot more time with people. They are doing things like rolling out nutrition programs, and they're doing all these really fascinating things. But that's a movement. I think it's called direct primary care. That's a movement that is in its infancy, but you can see that the institutions are being built and they're pushing back on it. So that's one way that we can see happening. But I mean, it is like you said too, you never know what's going to happen with reforms. And who knows what's going to happen under the Biden administration, and if that's going to be 4 or 8 years, and then after that as well. Because in some cases, like the direct primary care folks did get some carve outs at the federal level that allowed them to do a lot of this. But yeah, it would be nice to put the control back with the physicians and patients instead of government bureaucrats and insurance company and insurers.
Yeah, it doesn't seem like they should be the one deciding whether someone needs treatment or not.
Exactly.
Yeah. So
and that's a big fear you'll find politically in the United States, this fear that some government bureaucrat's going to decide what my health care is. Right now it's an insurance bureaucrat, but I'm just saying politically so that you can understand the political battles and stuff.
Do people mind it less that it's an insured than that it's a government employee?
They mind it still, but you can pressure an insurance company and create a PR nightmare. And there's ways that you can pressure a private company with the government. There's a sense of you can't fight City Hall, and what are you going to do? Like there's a sense of hopelessness once it gets to the federal government, once it gets to Washington, D.C. What are you really going to do? So I'm just telling you politically, these are the fears you're going to see. And I know that we don't usually, I think, scholars, when we talk about healthcare and healthcare reform, I'm just trying to explain to you what a lot of the people think, because I think we sometimes overlook that. And if we want to be successful, we should think about some of those things.
Yeah. So what about preventative medicine? Because it sounds like in the prepaid physician model, there was a push towards keeping people healthy. Because the thing it was the first thing I learned in health economics, and the thing that's always stuck with me is that we don't demand health care, we demand health. Healthcare is just a way of getting to more health. So the best system would actually be to have great healthcare and use it as little as possible, because people are healthy the longest. So, but then this whole preventative medicine is just not focused on or not even talked about, because the system is set up that nobody benefits from people being healthy.
That, and also you're not going to get, it's funny how the insurers have kind of tried to reimburse physicians for these things, but because they don't arise organically and everything has to come through a fee schedule, it's just really silly stuff, right? Like, oh, we'll reimburse you $30 if you talk to them about, I don't know, their diet. I mean, just silly things like that, right? And again, it's just the incentives aren't lined up. So let's imagine, say these were multi-specialty groups now, right, that they had developed. What would have probably happened is the prepaid group would have been responsible for that patient until, say, they hit maybe $250,000 or $500,000 or something, and then they would have had insurance kick in. from an insurance company, but the insurers never would have developed all this expertise in medical care, and right, they never would have had to become so involved in health insurance because they would have been so far on the back end, and there would have been so much incentive for the physicians to be keeping prices down in order to save themselves money, right? So if that were going on today, and that's the way it worked, and you paid your money to your prepaid group, imagine the incentives for that group, because they want to get as many patients as possible. I think you would see a lot of them kind of maybe somewhat specialized, say, oh, we tend to do more families, or we tend to do more kids, or we have a lot of diabetic, or we do a lot of elderly. Like say they had a lot of elderly patients. We're sending out a van to go pick you up to come to your appointment because we know it's hard for you to get here or whatever. Or, oh, we have a lot of diabetics. We're going to have a nutrition class once a month. And, you know, when you see your diabetic patient, you're not just like, okay, you have diabetes, you need to do better. Instead, you actually have programming set up, and you have people that are working with them. And then, oh, we have this exercise program over here. And so you can see how just because they're incentivized correctly, all of a sudden all these creative solutions are coming, up. Right now, there are no creative solutions can happen in a fee for service where every fee is scheduled, because if it's not on the fee schedule, it's not happening, right? So you can't just be creative and entrepreneurial, figure out cheaper ways to do things, better ways to do things, because you're not going to get paid for it. So you just have to work within the system. And so that's why we would want that to change.
So I have a couple final questions, and I mean, I could talk to you for way longer, but I have a couple final questions and then I'll let you go. What is a skill any researcher should learn?
To be corrected. I really think that is important. I'm a historian, so as I mentioned before, we look at primary sources, and I do love to laugh about how much I would like argue with the people in my primary source. I mean, they made, whatever the memo or the notes or the board of director meeting minutes or whatever, from whether it's the 1910s or the 1940s or 50s. And I'm saying, but don't you know that everybody says that that's not what you think? It's silly. I think the main thing is to allow yourself to be surprised. I think we hurt ourselves when we go in and we're like, I know what I'm going to find, and this is what the story is going to look like. And sometimes we also have ideological reasons we want to happen. I get that. I understand that. But what I try to tell my students is, and also it's scary when they start doing and saying things that you didn't expect them to and didn't fit your preconceived notions. But I try to tell them is, don't be afraid of that, because that is really where the most interesting things that you find when you're doing research and you're finding information that isn't at all like what you expect. Just let it be. You might not figure out at once, but just let it keep getting it. And eventually, once you figure out how it fits in, that's often where we make our biggest discoveries. That's often where we have, the biggest, spats of knowledge production, is by, really allowing ourselves to be surprised and allowing ourselves to learn new things and things to be not how we expect it.
Who do you admire or look up to?
Who do I? Are you looking for I don't know. Are you looking for a public figure?
No, anybody that you're like, this person is a great researcher. This person has done something that's fascinating. Anyone you're like, this is the reason I got into this field.
Well, I may be a little silly and not very professional, but I can't, because I guess I'm being put on the spot. I'm like, oh no, I want to say somebody. And I know after we're done with this, I'll be like, oh, I should have said that would have been great. That would have made me look so smart. But I'm just going to say, just because it's first thing to my mind, and because he did work for an insurance company, is my father, just because he taught me a lot when I was a kid about economics and looking at things economically. And that kind of just, I don't know, for some people, it's a logical thing for us, the way looking at markets. It's really fun to me. I feel very fortunate to have this job where I get to basically just map out markets and figure out what happened. But also I would say him too, because he taught me all these things. He's very smart, but also he sacrificed his life to raise 6 kids by himself. And so he's just a very good person. And so I admire him a lot.
That's amazing. What is a question you want me to ask that I haven't asked you yet?
I might have said something about talking more about the ACA and how hard the state exchanges have been on the beneficiaries, but we already talked about that a little bit, because that's a story that I feel like does not get a lot of airtime, and those people just suffer, but it doesn't make it to the media because it's not part of the whatever pre-approved narrative that, around, because we try to keep basic narratives in order to keep things coherent in the media, which can
So what's the
sometimes.
story? Because I agree with that. Very often the story gets made so simple that you don't understand the nuance, and then people get outraged, but it's not that simple, or it just gets swept under the rug and you're like, but it's more complicated than this.
Exactly. And to me, it is just how difficult the state exchanges have been, and how much the people who have to, so the people buying policies through the state exchanges under the ACA system are the people that the system is supposed to help. These are the people who were supposed to be the working poor, who couldn't qualify for Medicaid. And just, even knowing people, seeing this firsthand, hearing the stories of how expensive it is, how impossible it is to even meet the deductible, much less make the monthly payment, and how uninsured rates have not changed for this reason. And yes, you can make a law and say, we're going to fine you for not having it. Well, okay, great. But how compassionate is that? You just said, so now this person has to bankrupt themselves, they're going to get fined, but you're still not being compassionate. You're just being authoritarian about, this is our system and we're going to make it work. Darn it, all. And of who always gets the bad end of the stick. It's not the elites. It's not us people who design the program, set it up, or it's the people who have no connections and aren't elites and are going to suffer. They're just going to have to go without. So I wish there was a little bit more understanding and care for the people who are unable to still afford to buy the insurance.
Is that a problem that's part of the system, that it's so fragmented that people that work in government ministries of health that don't see the effects of their policies? Because in the Netherlands, we have a bit of the same, where it's like they come up with these ideas, they implement them, and then later we see that in hospitals it doesn't work because they implemented them, and now a hospital has to close, or they don't have these doctors because they already didn't do that many surgeries, and now they can't anymore. And it's all these effects that are, unintended consequences, of course, but is that because there is a lack of communication between the different groups in society, or where does that go wrong at the start, do you think?
I think it goes wrong because we try to set up programs that have to be managed. Like if you set up a program that has to be managed from Washington, think of how big the United States is. Think of how crazy different it is if you're in New Orleans versus Washington State. Culture is completely different. Just think about so if you're trying to run everything, yes, you're going to just you're going to be tripping over yourself with the number of unintended consequences. But you can set up reform programs in a way that allows them to be if you have the incentives right, you can set it up and let it go. Yes, of course, you still need people managing it and stuff, but that's why you got to get the incentives right so that everybody's incentivized to do as they're supposed to. And then, yes, you can have your regulation. It can be managed from DC and all, but very minimally with a light touch, and not this, draconian stuff on very minutia things that, like you said, unintended consequences and bad things happen. I think that's definitely the case. I understand a lot of people wanted to get ACA because this had been the dream for so long to have comprehensive healthcare reform. I can understand why it happened that way, but we also have to admit where we've made mistakes and say, hey, this didn't quite work out the way we wanted it to. I think if they had tried to get more buy-in, people might argue with me on this, but I really do think there's a way you could sell reform to a lot of people on the right as well. So.
Final question. What's your advice for future economists?
Well, so I really think historians and economists need each other. So I'm a historian, an economic historian. I think if you look at the discipline of history, we could use a little bit more understanding of economics. But then if you look at economics, they could use a little more understanding of history. In the United States, we have some really good economic historians, and I'm talking about historians who sit in economics departments. For example, in the subfield of like banking and finance, they tend to be really good. I would say in healthcare, that subfield hasn't quite arrived yet. And I would say the reason is, first of all, it's a newer field compared to banking and finance. within the discipline. But I think that for the economists, they'd be able to get the regression analyses and all their statistical regressions and, the very fine, you know how healthcare econ is. It's these very specific, if we change this one variable in the way, these types of physicians are paid, what will happen, right? It's these very small. They're going to ask better questions. They're going to, understand the way to set up their regression analyses and such much better if they understand the history. A lot of people think, oh, healthcare, it's so hard to understand. It's such a complicated system. But what I've tried to tell you throughout this podcast is, let me just tell you a story. Right. That's what we historians excel at. That is actually going to make a lot of the complexity kind of, fall into place. And so that even as you encounter smaller details, it makes sense because you can see the forest and you see where that leaf goes up on the tree. Right. So that would be my encouragement to economists, is to understand the history, and not just a little bit, not just superficially, but really broadly, because then when you're looking at those tiny little variables that you want to study, you're going to do it in a correct way. Because what I'll do, I'll see them asking questions and trying to run the data for questions that just are nonsensical and not important if you understood the bigger picture. Does that make sense? So that's why I would say understand the big picture, and then you can go in and look for the data that you're looking for and run the numbers and do all that. But we need each other, right? They have every right to come when they come over to the historians and make fun of us for not, thinking economically enough about stuff. We both disciplines have their weaknesses.
Christy, thank you so much for being on the podcast. This was amazing.
Oh, it was so much fun. I really appreciate you having me on. Thank you so much.
Thank you for listening to the Rethinking podcast. Hit the follow button on your platform so that you'll stay up to date with all we have in store for you. You can also find Rethinking Economics NL on social media. Just click the links down below. Until next time, we'll rethink again soon.